I'm Dr. Fakir Abadi, and this is type 2 diabetes diagnosis and glycemic targets in adults. There are many clinical practice guidelines for type 2 diabetes out. For example, there is the American College of Endocrinology, American Association of Clinical Endocrinologists, or ACE, and of course there's the American Diabetes Association guideline, which most people are familiar with. Every December, ADA releases a new guideline. Let's see what the 2019 ADA guidelines recommend. Generally speaking, diabetes can be classified into four categories. There's type 1 diabetes, which is generally due to autoimmune beta cell destruction. There's type 2 diabetes, which is usually due to progressive loss of beta cell insulin secretion. There's gestational diabetes, and of course there are diabetes due to other causes. Traditionally, type 2 diabetes was thought to occur in adults and type 1 diabetes in children. However, that is no longer accurate, as both diabetes occur in both age groups. I will focus on type 2 diabetes. In this picture, you can see the progression of type 2 diabetes. Of course, people who have normal endocrine function can develop prediabetes over time. There are about 84 million people in America with prediabetes, and most of them do not know it. Without intervention, prediabetes will progress into type 2 diabetes. About 30 million people in the US have type 2 diabetes. And we can actually do primary prevention to prevent progression of prediabetes to type 2 diabetes. For example, diet and exercise can prevent prediabetes from progressing into type 2 diabetes. Once patients have type 2 diabetes, over time, this can progress into having complications. Therefore, it is important for type 2 diabetes patients to have secondary prevention to prevent those complications. These complications include the microvascular complications and macrovascular complications. And of course, once patients have complications, this can progress into disability and ultimately death. And we can do tertiary prevention for patients who have complications in order to prevent those disabilities and to reduce mortality. We have three diagnostic tools for diagnosing diabetes. There's fasting plasma glucose, there's the 2-hour plasma glucose, and there's of course A1C. Now when you compare these three tests, the 2-hour plasma glucose can actually diagnose more people with prediabetes and diabetes compared to fasting plasma glucose and A1C. The A1C is the gold standard, but it has advantages and limitations. The advantages are that it's convenient because patients are not required to be fasting. There's greater pre-analytical stability. There's less day-to-day perturbations during stress and illness. However, A1C is actually more expensive. It has lower sensitivity. There is imperfect correlation between A1C and average glucose in some individuals. It does not provide the measure of glycemic variability. For example, it doesn't tell you what's the value for fasting and postprandial blood glucose, and it also doesn't tell you anything about hypoglycemia, and it may underestimate or overestimate mean glucose. Furthermore, there's variability in A1C depending on race, ethnicity, and hemoglobinopathies. For example, higher A1C levels in African Americans than in whites have been reported at a given mean glucose concentration. However, most assays in the US are unaffected by most of these variants. There are also other conditions that may result in discrepancies between A1C results and true mean glycemia. And these are typically conditions that are associated with increased red blood cell turnover. For example, patients with sickle cell disease, pregnancy, people with end-stage renal disease, patients who have recent blood loss who required transfusion, or patients who received erythropoietic therapy, as well as patients with HIV treated with certain drugs and patients with anemia. For example, one study showed that HIV patients who were receiving non-NUCs or NNRTIs, in those patients, A1C actually underestimate the level of glycemia, whereas patients who were receiving HIV protease inhibitors, A1C actually overestimated the level of glycemia. So A1C is not the best in those patients. So here are the recommendations from ADA. So ADA for diagnosis, they actually have 28 recommendations. I selected some of the important ones. So their second recommendation is marked discordance between measured A1C and plasma glucose levels should raise the possibility of A1C assay interference due to hemoglobin variant. So in fact, they actually recommend that in conditions associated with an altered relationship between A1C and glycemia, such as sickle cell disease, pregnancy, HIV, hemodialysis, recent blood loss or transfusion, or erythropoietin therapy, only plasma blood glucose criteria should be used to diagnose diabetes instead of A1C. And here are the criteria for diagnosis of type 2 diabetes. So if you're using fasting plasma glucose, the cutoff is 126. And I know 126, it sounds like a random number, and it's because these studies were done in the UK, and they used the 7 millimole per liter, which when you convert it to milligram per deciliter, it translates into 126. But that's the cutoff that we use. So fasting plasma glucose of 126 or higher is the diagnosis of type 2 diabetes. Or if you're using the 2-hour plasma glucose, the cutoff is 200. Or with the A1C, it would be 6.5% or higher. And of course, in patients with classic symptoms of hyperglycemia or hyperglycemic crisis, just a random plasma glucose of a 200 would be sufficient. Now, these, the first three, you actually need to have two values. So for example, if you get a fasting plasma glucose of 126, you have to check again to confirm that it's to make sure that it's not an error from the assay. Now, when you confirm, you can use the same test, or you can actually choose to do a different test. So if you got a fasting plasma glucose of 126, you can actually get the A1C of 6.5. Since you got two abnormal values, you can diagnose diabetes. Or if it's you want to use fasting plasma glucose twice, it can be actually done from the same blood sample. And that's something that's new this year. You can use two tests from the same blood sample as opposed to asking the patient to come back for follow-up or getting a different blood sample. And the reason that you need to confirm these tests is because all of these tests have pre-analytic and analytic variability. So it is possible that an abnormal result, when repeated, will produce a value below the diagnostic cut point. Now, I will briefly mention, so these are the criteria for screening for pre-diabetes. So patients who are overweight or obese, along with the risk factor for diabetes, they should be screened. Otherwise, anybody at the age of 45 or older, should be screened for pre-diabetes. And here are the criteria for diagnosis of pre-diabetes. So the fasting plasma glucose would be 100 to 125, or a 2-hour plasma glucose of 140 to 199, or if you want to use A1C, 5.7 to 6.4%. And here's a visual presentation. So if you're using the fasting plasma glucose, so anything less than 100 is normal. So that's what you want to tell patients at, for example, at the health fair. If someone's fasting plasma glucose is between 100 to 125, they have impaired fasting glucose, so they will be diagnosed with prediabetes. And at 126 and higher, they will actually have type 2 diabetes. Compare that to A1C, so we want patients to have an A1C of less than 5.7, but if they have 5.7 to 6.5, they actually have prediabetes. And if they have an A1C of 6.5 or higher, they actually have type 2 diabetes. Now let's talk about patients with type 2 diabetes. So once someone has type 2 diabetes, we want to make sure that we prevent some of these complications. And these complications include macrovascular and macrovascular complications. So macrovascular complications are coronary artery disease, peripheral vascular disease, and cerebrovascular disease. Macrovascular is retinopathy, nephropathy, neuropathy, and diabetic foot ulcer. And these are something that occur chronically. So you want to, these are not things that you want to prevent over a few days. So for example, if someone is hospitalized, for example, someone got into a car accident and they're in the hospital, the goal is not to prevent this because these don't occur over a few days. They occur over many years. So this is mostly chronic management for outpatient. Whereas for acute management, you want to make sure that we make, if the patient has infection, we want to treat it, and if they don't, we want to prevent infections. And of course, in an acute care setting, We want to prevent hypoglycemia and hyperglycemia that are, they can have more of an impact on the patient acutely. These are also, the hypoglycemia and hyperglycemia are also important chronically, but even more so in an acute care setting. And of course, mortality can occur even more in the acute care setting. So that's the goal, to prevent in acute care setting. Now, cardiovascular disease is a more common cause of death than macrovascular disease. So even though all of these can lead to death, macrovascular complications are more likely to lead to death. Now, for glycemic targets, ADA has 13 recommendations. The first one is that A1C test should be performed at least 2 times per year, and quarterly in patients whose therapy has changed, or if the patient is not at goal. Now, a reasonable A1C for many non-pregnant adults is less than 7. Now, note that they say a reasonable, so it's not to say that everybody's goal should be less than 7, but they say it's reasonable that for most people it should be less than 7. Also, keep in mind that other guidelines have different recommendations than ADA, so you may work with clinicians that follow other guidelines. Their 7 recommendation is to reassure glycemic targets over time based on the criteria in figure 6.1. Which I will show you in a little bit. And of course, they say that glycemic targets must be individualized in the context of shared decision making to address the needs and preferences of each patient and the individual characteristics that influence risks and benefits of therapy for each patient. Now, note that the focus here is on A1C, because A1C actually reflects average glycemia over approximately 3 months. So that's the primary target, and I'll talk about the other targets in a little bit. Now, they do say that you can actually, use more stringent A1C goals, such as A1C of less than 6.5 for certain patients. You can also have less stringent A1C goal. For example, A1C of less than 8% for some patients, and they give you that figure 6.1 to decide. And here's that figure. I know there are 3 landmark clinical trials out there. So there's the ACCORD trial, there's the ADVANCE trial, and there's the VADT trial. And collectively, when you look at the data from those 3 landmark studies, along with all the post-hoc analysis from those studies and the long-term follow-up studies, it has been determined that so in the middle you have 7, and then you want to be more intense and less intense depending on the patient. So some of the things that you may consider is, for example, does the patient have hypoglycemia risk? If the hypoglycemia risk is high, then you want to be less intense. So you may want to target A1C of less than 8, because you don't want to. So it's a risk versus benefit. You don't want to cause too much hypoglycemia. Versus if the patient has a low risk of hypoglycemia, you can actually target 6.1. Another thing to consider is if the patient has had a long-standing disease duration. So if they've had a diabetes for 20 years, then you may want to go with less intense. Whereas someone who was just diagnosed, you may want to go more intense in order to avoid some of the macrovascular complications that the patient may not have developed yet. For example, neuropathy. Another thing is life expectancy. So if someone's life expectancy is short, you can actually be more lenient, versus if they have a long life expectancy, you can be more intense. If they have a lot of comorbidities, you can be more lenient. If they already have established vascular complications, more lenient target. And if someone has limited access to resources, for example, their insurance or transportation and things like that, you may want to be more lenient, because you don't want that to be a barrier to treatment. And of course, you also want to consider patient preferences. So if patient is highly motivated, excellent self-care capabilities, you want to be more intense. Whereas if someone's preference is for less burdensome therapy, you can be more lenient. So this has to be, shared decision making, is that you consider all of these and you discuss it with the patient and you come up with a plan that's right for the patient. Now, the focus so far was on A1C. There are some epidemiologic studies that suggested that elevated post-challenge or 2-hour plasma glucose values have been associated with increased cardiovascular disease. However, intervention trials have not shown postprandial glucose to be a cardiovascular risk factor independent of A1C. So A1C is good. In fact, one randomized controlled trial in patients with known cardiovascular disease found no cardiovascular disease benefit of insulin regimens targeting postprandial glucose compared with preprandial glucose. So therefore, ADA says it is reasonable for postprandial testing to be recommended for individuals who have pre-meal glucose values within the target but have A1C values above target. Measuring postprandial plasma glucose 1 to 2 hours after the start of meal and using treatments aimed at reducing postprandial plasma glucose to less than 180 may help lower A1C. And this is a chart that will come handy when you have a patient with A1C but they haven't been measuring their plasma glucose, including fasting, pre-meal, and post-meal. So you can kind of use this chart to estimate. So if you have somebody's A1C, you can kind of estimate what their fasting glucose is gonna be. So they give you like ranges that correlate to A1C. Now keep in mind that these are just estimates, so it may not actually be true in your patient. There's huge variability, but it's better than nothing. So it's a useful tool. And finally, these are the glycemic targets for outpatient. So inpatient, we have different targets, which I will talk about in a separate video. But for outpatient, in ambulatory care clinic, in outpatient setting, glycemic targets are A1C of less than 7 for most patients. Of course, you can have more strict or more lenient targets, but generally speaking, A1C of less than 7. And preprandial capillary plasma glucose of 80 to 130. So you want to target fasting plasma glucose of 80 to 130. And you want to peak postprandial, and postprandial will be 1 to 2 hours after the beginning of the meal to be less than 180. So these are the 3 numbers that you have to know for your rotations. And keep in mind that these numbers may not be in agreement with other guidelines out there, but at least the 2019 American Diabetes Association recommends these numbers for most patients. Again, these are guidelines. They're not to replace clinical judgment. Always use your judgment to decide what's best for your patient. This concludes this presentation.